Okay, so thank you all for coming. So we're going to talk tonight about basically women and ADHD and the impact of hormones, looking at it from, all the way from childhood up to older adulthood. And so I do lots of speaking, teaching in this area. I'm currently the vice chair of CADDAC, which is our national ADHD organization that writes the guidelines and tries to help educate clinicians who work in the area of ADHD. I'd like to thank CADDAC for hosting tonight. I think this is a really important area. It's an area that I have a lot of interest in. I treat adults with ADHD in the outpatient setting, and many have comorbidities. And so tonight we're going to be looking at how ADHD presents in the female population with some of those common comorbidities. We're also going to look at the literature on hormones and ADHD through the lifespan. We'll touch a bit on treatment strategies in ADHD during pregnancy and postpartum, because that's definitely kind of a hot topic, as well as the hormonal impact of menopause on cognition. Okay, so I always find it sort of helpful to think about like the day in a life of somebody living with ADHD. So speaking from my own world, I'm a full-time working mom. I have 2 teenage boys, and we're surviving COVID. My husband normally travels half the time. We help out with my 5-year-old niece. We have a dog. We have lots going on in the house. My kids usually play a bunch of sports, and so I'm usually running all day, every day from the moment I get up. And as we know, it's oftentimes the moms who end up staying home postpartum to look after the baby, the newborn, and take maternity leave. And so then we take on a lot of the household responsibilities, from kind of day one of having children. And that seems to sort of continue even once we go back to work. And in lots of situations, I think those responsibilities don't get automatically divvied up when the mom goes back to work. And so that sort of continues through life. And so once you are in this world where you've got kids and you've got a job and you're running a house and you've got, a spouse or not, there's lots of juggling to be done. And so I know for me, from the moment I get up in the morning, I'm sort of making sure my kids are up and out of bed and showered and having a good breakfast, and do they have their lunch ready to go, and do they have a test today, do they have the schoolwork they need, do they have the sports equipment that's necessary for that day. And one kid was home today, so I have to make sure I call the school and let them know what's happening, and that he's sort of taken care of. And then, that carries on even while I'm at work, getting texts and phone calls. And so it's sort of continuous. And outside of COVID, normally I'd be racing from work to a sporting activity or a music lesson or that kind of thing, and then home to make sure dinner's happening. And as the kids get older, the time they go to bed gets later and later. And so I sort of find that at the end of my day, I want some me time. And I think all of us do. And, in this era of Netflix and so on, oftentimes that's something I might want to do, is watch a show or read a chapter in a book or that kind of thing. And so I know for me, that once I've watched one show or read one chapter or so on, I need to actually go to bed, because I need my sleep so I can get up and repeat tomorrow. If you take somebody who has a similar sort of world to mine, with lots of responsibilities and lots of juggling, and you put an ADHD brain in that picture, what you actually find is that those challenges are much more significant and much more overwhelming, and that the ability to stay on top of all the have tos and need tos and want tos can become very, very overwhelming. And so, trying to stay on top of not only oneself and one's responsibilities, and trying to get up on time and out the door and at work on time, while also managing kids, and some kids with ADHD perhaps, and dealing with whatever is going on in terms of being late and losing things, and fights that are happening and so on, is that much more difficult for for a woman with ADHD. And so for that individual, by the time things are shut down and they want some me time, they might want to do the exact same things that I do. But what we know in ADHD is that once an individual with ADHD is doing something they want to do and they're choosing to do, they get into hyper focus mode because the dopamine, the pleasure reward neurotransmitter, starts flowing. And so even if the intention is to shut things down after, half an hour, an hour, so that they can have a good sleep, once people get into that hyper focus mode, the tendency is to lose track of time. And so they might go hours and hours before they actually realize and look at the clock that it might be 2, 3 a.m. And so then they're anxious and stressed out and, oh my God, I'm not going to get enough sleep. And so it's even harder to fall asleep. And then their ability to feel rested and actually get up on time when the alarm goes off in the morning already sets them behind. And so they're lucky if they actually do hear that alarm and respond to it and get up and get the household going and aren't in fact late and losing things and forgetting things. But more often than not, that is what happens, that things are lost and forgotten, and there's yelling and fights and forgotten items, and breakfast might not happen and lunches might not get packed and kids might be late for school and that mom might be late for work. You show up late for work and you're sleep deprived, your ADHD is going to be that much more impacted, with more distractibility, less ability to stay on task, more likely to go down rabbit holes, more likely to be sort of sleepy and forgetful and making mistakes, but also more likely to be irritable and impulsive and maybe get into conflicts with coworkers or the boss. We also know that, people can have the impulse to not do things. And so it might actually transpire that the alarm goes off and the thought is, forget it. It's too much. I can't even deal with this. We're just all staying home today. I'm not going to work. The kids aren't going to school. So as you can see, and I'm sure many are kind of relating to what I'm describing, that trying to live and survive and stay on top of everything with ADHD can be extremely difficult and can cause a lot of anxieties and really impact mood and lead to, self-medication. So it's good to just briefly review ADHD. So ADHD is a neurodevelopmental disorder that's highly inheritable, and it affects all aspects of a person's life. So it's not just about school or work. This is relationships as well as academics and work, but also the ability to make decisions, how one drives, the tendency to get into legal difficulties, more risk of using substances to self-medicate. And we know that medications are the primary aspect of treatment, because this is something that's been researched over many, many years, and medications have been found to be extremely effective in treating ADHD. And it is a chronic illness, often requiring long-term or lifelong management. And when it's not treated, there's an extremely high burden of illness. So in our, DSM diagnostic manual in psychiatry, the subsets of ADHD include inattention, hyperactivity, and impulsivity, but this emotional dysregulation piece is not formally included, but it affects probably 90% of people with ADHD. And sometimes the emotional dysregulation is in fact the most hindering or impairing portion of a person's ADHD. And it's not always a piece that responds as well to the medication piece. ADHD presents differently in kids and adults. So, where we see in kids, it's really obvious when they're not paying attention, that they're not looking at you when they're talking, they're, seeing the bright shiny object, or not answering to questions when they're asked, and clearly not following through on things, losing things constantly, very disorganized. Adults tend to sort of have learned how to better at least fake it, making eye contact, nodding, appearing to pay attention. But if something's more interesting inside the brain, that's going to be distracting. Or if something's more interesting externally, that's also going to be distracting. So it's the tendency to not be following conversations that well, kind of mind being, elsewhere in a daydream world or an internal world. And this sort of leads to a lot of anxieties for people when they can't respond to questions that are asked for them, or they know they said they do something, but they can't recall what it is and they're too embarrassed to ask. And so then that kind of leads to difficulties at work or in relationships. Also, that tendency to kind of get distracted or sidetracked can lead to not actually finishing things that are important, like work related or school related. Lots of people have time management difficulties, time blindness, where, you know, thinking things can get done in a certain period of time, but actually it takes much longer, and then always sort of running late, and the tendency to sort of lose things that are important. But procrastination is probably one of the biggest things that individuals with ADHD struggle with, because it really does come down to that neurobiology. If something is not interesting and stimulating and is not driving dopamine in the brain, or it isn't super important and there isn't a clear deadline, so it's not driving norepinephrine in the brain, that the brain functioning is almost offline. And so when something is on that list to do and it's not interesting and stimulating, or it's not important and doesn't have a deadline, the tendency is to put it off and put it off and put it off until it absolutely has to be done. And so that can lead to many, many difficulties in day-to-day life. When we look at the hyperactivity impulsivity, again, it's very overt in kids, like not able to sit still, moving, driven by a motor, bouncing around, pushing, shoving, blurting, interrupting. In adults, again, that tends to be sort of controlled a little bit better, but that doesn't mean that it's gone. Oftentimes we find that hyperactivity becomes either displayed as sort of fidgeting, so tapping toes, bouncing legs, biting nails, picking at skin, playing with hair, doodling. If there's no outlet for the hyperactivity, it gets internalized, and people describe feeling this like restlessness, where they're sort of feeling like agitated, and sometimes they think that that's anxiety. And it's hard for them to, you know, stay seated for long periods of time, and also the tendency to sort of talk or over talk or blurt or interrupt. But what we also see is this sort of impulsivity leading to lots of addictive behaviors. So higher tendency to engage in self-medication with drugs and alcohol, caffeine, but also gambling, sex, porn, internet, binge eating. Those are also much higher in individuals with ADHD. So this is just to highlight that high heritability. So this really runs in families, but it can present very differently within one family. You might have a parent who's more sort of inattentive and a child who's more hyperactive, impulsive. So ADHD also presents quite differently between males and females. We know that boys are diagnosed at a much higher rate than girls, and the rates are actually astounding. It's all the way from 3-to-1 to 16-to-1, but by adulthood, the prevalence is almost 1-to-1. So it really does beg that question of what's sort of happening to all of these girls who aren't getting diagnosed and treated, but then are getting picked up as adulthood. Even in Canada, what we see is that prescription rates for ADHD show that more boys are treated than girls, but then more women are treated than men. So it's all these girls sort of with ADHD who are being left undiagnosed and untreated, and oftentimes actually getting misdiagnosed or treated for other conditions. And this has a lot of long-term social as well as educational and mental health outcomes. So why is this that boys are picked up more than girls? Well, boys are more likely to suffer some of the disorders that present earlier in life, like learning disorders or oppositional defiant disorder, whereas girls tend to develop more of those sort of emotional disorders kind of into adolescence, so depression, anxiety, and eating disorders. And those are the ones that tend to sort of come to attention. And it's actually those conditions that end up being treated, and the ADHD sort of gets ignored or left in the background until adulthood, when they start to realize this treatment isn't as effective as it should be, and I'm still having struggles, and start to investigate further. The other thing that we know is that if individuals have a lot of anxiety, they're sort of embarrassed, they don't want to stand out, they don't want to, they want to be people pleasers. And so that can actually control some of those sort of hyperactive impulsive symptoms. When we look at hormones in the sort of realm of ADHD and gender, and we look at dopamine as well, what we see is that with these externalizing behaviors of boys, that sort of presents as that hyperactivity, impulsivity. And why is this? Well, the hypothesis is that sort of as dopamine receptors are increasing in males, it's around that same time that we see those early motor symptoms. And then they're getting into trouble. They're getting into trouble in the classroom or at home or in school or in sports settings or other sort of social settings. Whereas girls tend to sort of present a little more sort of shy, quiet daydreamer when they're younger, which is not to say all girls are like that. There are certainly the girls that are more hyperactive and impulsive. But then around sort of adolescence and puberty, when the hormones kick in, is when we see sort of the shift in presentation and more likely to start to come to attention. And when we sort of look at the literature, what's being found in adolescent girls with ADHD, that they end up struggling with sort of lower self-efficacy, struggling with coping strategies, these higher rates of depression, anxiety. But they can also then start developing some more of that impulsivity, which is right around that time when, again, the hormones are kicking in, and it can lead to sort of impulsive sexual encounters without protection. So we see these higher rates of sexually transmitted infections and unplanned pregnancies in adolescent girls with ADHD. When we look specifically at Canadian women, kind of 20 to 40 with ADHD, we see all these sort of higher rates of difficulties. So 3 times the rate of insomnia, pain problems, suicidality, a history of childhood sexual abuse and anxiety, and double the rates of substance abuse, depression, smoking, poverty, and a history of physical abuse in childhood. So this really suggests that the women with ADHD are quite vulnerable to adversities that present earlier in life, but then result in these sort of health and mental health problems later in life. And that on average, women with ADHD end up in sort of lower socioeconomic statuses than their non-ADHD peers, and can have struggles in their relationships as well as social activities and just day-to-day responsibilities. So the neurobiology of ADHD, so this is something I teach my colleagues about, but I also like to teach my patients about, because I think it's important to understand how your brain works and why ADHD impacts people the way it does and why we use the treatments that we do. So we know that there's this thing called executive functioning. So this is sort of that higher level brain functioning that allows us to think, to plan, to prioritize, to set goals, but also to regulate emotions and control impulses. And when we look at what are the key sort of neurotransmitters in the brain responsible, they are serotonin, norepinephrine, and dopamine. And there's lots of overlap in their functions. The key neurotransmitters in ADHD are dopamine and norepinephrine. So I've mentioned those. Dopamine is our reward pleasure neurotransmitter. So again, when you're doing something that's naturally interesting and stimulating, new, challenging, it will naturally increase the dopamine in the brain, leading to that sort of hyper focus that occurs, and that will stay in place until the interest and stimulation wears off, and then again kind of hard to maintain focus and attention. And then the norepinephrine is like our adrenaline system, so that kicks in when something's really important or a deadline hits. And so what we see in the brains of individuals with ADHD are sort of lower than normal levels of those neurotransmitters, but that they also fluctuate significantly. So when something's interesting and stimulating or really important, we see these higher levels of dopamine and norepinephrine, and that brain being really online and really engaged and very effective. But then as soon as that wears off, it's really hard for individuals with ADHD to even get started on the most basic tasks. And that leads to a lot of that difficulty with sort of procrastination, initiation, and follow through. So now we're going to kind of look at estrogen and brain functioning. So estrogen affects sort of a lot in as women. So our mood, how we regulate our emotions, but also our memory, our executive functionings, and our circadian rhythms. And the fluctuations that happen in estrogen then therefore impact our mood and our ability to think, and can cause physical symptoms. So during periods when estrogen is lower, we see increased risks of depression, increased risks of anxiety, as well as difficulties with cognition, and an increase in ADHD symptoms. So when we look at the hormonal shifts during the menstrual cycle, which we know starts in usually early adolescence, what we see is that the symptoms of ADHD sort of vary across the menstrual cycle in response to those hormonal changes. So mid-cycle, sort of technically day 14, is when we have ovulation, and that is the peak or the highest level of estrogen. And as soon as ovulation happens, estrogen starts to drop off and we see the rise in progesterone. The dopamine, as you can see, sort of follows fairly closely with the estrogen. And as we talked about, dopamine is so important for that brain functioning. And so what we really see is that women with ADHD tend to do better in the first couple of weeks of their cycle as the estrogen and dopamine are rising, and then have more struggles as the estrogen and dopamine decrease and the progesterone rises. So we also have found that in that sort of earlier phase up to ovulation, women actually respond a lot better to their medications, whereas they have worsening of symptoms of ADHD and less response to the medications kind of in that PMS period when progesterone is highest. So that suggests that it might be worthwhile to shift the dose or tweak the dose of an ADHD medication along these lines. So finding the base dose that works well, but then actually increasing it during that PMS period of time to sort of counteract the effect of the dropping estrogen and dopamine. So estrogen is pretty important for us as women. And when we have these decreases, it can lead to the diminishment of our executive functioning, the increase in ADHD symptoms, and this increased risk of impulsivity, which can lead to unprotected sex. And then we see again that sort of increased risk of STIs and unplanned pregnancies occurring right at the time when a woman is most fertile. So when we look at kind of the course of ADHD over time, what we sort of see is that inattention continues to be sort of something that brings people to, their doctors or their clinicians. The hyperactivity, impulsivity doesn't go away, but people tend to find better ways to sort of manage it. But what we see is comorbidity of other conditions increasing over time. And so in kids, up to 90% will have at least one other comorbid condition, and in adults, 85% have at least one condition alongside of their ADHD. And sometimes when we actually treat the comorbid illness or the illness that has developed subsequent to the untreated ADHD, it can actually cause worsening of the ADHD. So this is something that when we kind of look at as clinicians, we look at sort of these common other disorders. So MDD is major depressive disorder, bipolar disorder, the depressed period of bipolar disorder, anxiety disorders, and substance use disorders. And so when you look sort of across at the different symptoms, what you see is there's lots and lots of overlap. The one that has the most overlap in symptoms is the hypomanic period of bipolar disorder. So, this can be a challenge for clinicians to sort of differentiate because hypomania in bipolar disorder is defined as having at least 4 days or more of decreased need for sleep, increased energy, increased goal-directed behavior, increased impulsivity without sort of thinking about the consequences of one's actions. If any clinician has ever asked you or ever asked anybody with ADHD, have you ever gone through a period of time where you haven't slept as much, you've had more energy, you've been more impulsive, you've been sort of more speedy? Almost everyone with ADHD would say yes to this. And so a lot of people with ADHD actually get diagnosed with bipolar disorder. But it's important to tease apart some of the differences. So most people with ADHD will have had that happen for a day or two during a time when their dopamine surges because they're doing something really interesting and stimulating and rewarding and challenging, like, they're decorating a room, or they're working on an art project, or they're into a new video game or a Netflix series or something that's like really driving them for a period of time. But that dopamine doesn't last forever. And when it dips off, those behaviors, that drive dips off as well. So the duration isn't as long for someone with ADHD. It's usually context dependent. So there's something going on that's driving it. And the third thing that's different between ADHD and bipolar is that after a hypomanic or manic episode in bipolar disorder, people will have a severe depression for the most part. People with ADHD don't get depressed after their dopamine wears off or the norepinephrine wears off because they had a big deadline and they were going for a couple of days to get it done and not sleeping as much. They'll usually kind of be sleepy and, you know, tired for a few days and then go back to sort of baseline. That being said, these two disorders actually do sort of run together. So about 20% of people with bipolar will have ADHD, and about 20% of people with ADHD will have bipolar. So it's really important to assess for both. And if both are present, to first treat and stabilize bipolar disorder and then circle back and treat the ADHD. Because if you don't treat ADHD in someone with bipolar disorder, the bipolar disorder is not going to be very well managed. Another very common comorbidity with ADHD is depression, because living a life with untreated ADHD can be depressogenic. It can make you feel down and depressed when you know you're capable of many, many things. You can have these periods of extremely high functioning and productivity and efficiency, and then these other times that just feel demoralizing because it's so hard to get started on things or follow through on things that you say you're going to do. Some of the big overlaps obviously are around concentration. So in depression, somebody will become more challenged in terms of maintaining concentration when they get depressed, whereas somebody with ADHD will have this, you know, variable concentration throughout their life, depending on how interested they are, or how important something is. Another big overlap is sleep. So many people with ADHD have struggles with sleep that are lifelong. It's hard to shut your brain off at night when nothing else is interesting or stimulating except your own thoughts and ideas. And it can be stimulating because it's interesting, or it can be stimulating because it's stressful. And that can keep people up. It can also, you know, lead to restless sleep or people staying up later and later and what we call sleep-wake reversal. So again, if you have both of these, if you have depression and ADHD, if they're sort of equally problematic or the ADHD is causing more problems, that should be treated first, because sometimes treating ADHD actually leads to a lot of the sort of relief or resolution from the depression. When we look at anxiety, this is sort of one of the highest comorbidities with ADHD at about 50%. And what we call generalized anxiety disorder, which is sort of worrying about anything and everything and having trouble controlling one's worries, often sort of gets diagnosed in people with ADHD. But if you actually stop and sort of say, like, what are you worrying about? Lots of times the worries are related to the ADHD. Well, I can't remember enough, and I keep losing things, and I'm late all the time, and I keep procrastinating, and I keep telling myself I'm not going to blurt tonight. I'm not going to do anything stupid, but then there's no braking mechanism and it happens before you can stop. That can lead to a lot of anxiety and worries. It can also lead to a lot of social anxiety where, you know, you're not tracking what somebody else is saying. And so when they ask you a follow-up question, you can't answer them, or, you know, you've lost your train of thought, like mid-sentence. So there are a lot of, again, anxiety disorders that can come alongside of ADHD. And again, if the anxiety is sort of equally problematic to the ADHD or the, you know, not as, then it makes sense to first treat the ADHD. And ADHD medications are called stimulants because they stimulate dopamine and norepinephrine, not because they stimulate the person. And so in fact, ADHD medication should have a calming effect. So people with anxiety often feel less anxious when their ADHD is treated. Borderline personality disorder is one that a lot of women get misdiagnosed with who have ADHD. So 11% ADHD rates in teens who have borderline personality disorder. And this is because of the overlap in symptoms, particularly the impulsivity and the emotional dysregulation. So anyone who's ever had a diagnosis of borderline personality disorder should be assessed for ADHD, because oftentimes they're misdiagnosed or both come together, and treating the ADHD will help a lot in resolving those symptoms that look like borderline. All right, so now we're going to look at pregnancy and ADHD. So any of you who have been pregnant would know about what happens to your brain. So during pregnancy, there's definitely increased sort of distractibility. There's difficulties with memory, concentration, and this is often being fondly called pregnancy brain. But what we are starting to sort of understand is that changes in hormones are actually causing that impairment in cognition. So there are some studies, so this meta-analysis from a couple of years ago showed significantly worse cognitive functioning, as well as memory and executive functioning in pregnancy compared to controls. And this was particularly evident during the third trimester. So women assessed during the third trimester and in the postpartum period compared to non-pregnant women had lower verbal memory and actually lower processing speed scores. This study, now almost 10 years old, actually found a relationship between prolactin levels and cognitive functioning. So we know prolactin increases during pregnancy and in breastfeeding or lactation. And so it was found that higher levels of prolactin may actually be, detrimental or negatively impact executive functioning. And so what they found in this study was that both high and low levels of prolactin would have a negative impact on verbal memory, whereas moderate levels were optimal. So when we look at treating ADHD, when I'm working with any patients, I want to know, A, do you have the symptoms? Are the symptoms impairing? Okay, then we need to treat you. What are your treatment goals? And what can you reasonably expect in treatment? So this is not just a magic pill that's going to take everything away. It's kind of like the glasses analogy. So, when you get glasses, yes, you can see better and more clearly, but you don't suddenly get smarter or develop a new skill set or have X-ray vision. Similarly, what we want with the medications is that they target and normalize the dopamine and norepinephrine so that the playing field is level. And so that then there is the greater capacity to be more consistent and develop more skills and strategies. And it's really important, to be treated with long-acting stimulants as opposed to short-acting stimulants, because what we want is sort of a smooth sort of delivery of the medication that lasts throughout the waking hours of the day. So these are the 5 long-acting stimulants available to us in Canada. 2 fall in the class called amphetamines, and those would be Adderall and Vyvanse. And then 3 are methylphenidates, and those are Bifenton, Concerta, and Foquest. And what we know is about a third of people will do better on the amphetamine class, another third on the methylphenidate class, and then another third can do well on either. So again, it's really important once you have a diagnosis that you get started on one of these medications at a starting dose, and that it's gradually increased by the increments sort of indicated here, or the smallest sort of increment, until you get to a point where it feels like you've sort of hit a sweet spot and that the symptoms are under good control without a lot of negative side effects. This, just to make this sort of really understandable and basic, when we look at effect size, the higher the number, the more effective. And antidepressants are 0.5, non-stimulants are 0.6, and long-acting stimulants for ADHD are 0.95. So they're almost double the effect size of antidepressants. So this is why if someone has both depression and anxiety, or ADHD and depression, or ADHD and anxiety, that it makes sense to first treat the ADHD with a medication that's twice as effective as an antidepressant. And in fact, some of our antidepressants, particularly the SSRIs, can sometimes have over time a negative effect on cognition and on ADHD by sort of decreasing the dopamine and norepinephrine. So if you're being treated for depression and anxiety, it's important that the particular medication used is actually a good choice for someone with ADHD. So this is getting into the sweet spot. So if your levels of dopamine and norepinephrine are insufficient or too low, that leads to ADHD symptoms. But if they're too high, that also is not effective, and it can lead to feeling overstimulated and having difficulty shifting attention from one thing to another. So what we want is to get people into that optimal middle level where there's just like a balance of dopamine and norepinephrine. So instead of high, low, it's kind of just fluctuating in sort of that, average kind of level. so that people are better able to manage their symptoms. When we look at side effects, these are the most common. So I tell patients, the most common are dryness, dry eyes, dry mouth. So it's important to drink lots of water. They can reduce your appetite or cause a bit of stomach upset, but eating will help with that. So you need to eat when you take your meds in the morning, and you need to remind yourself to eat midday, even if you're not hungry. And then usually by evening, people are hungry again. Insomnia usually is not a side effect of the medications. It's usually something people already struggle with. And in fact, the studies show that after about a month on, a good dose or a therapeutic dose of medication, that sleep either improves or returns to baseline. We usually don't see increases in blood pressure and heart rate unless people are consuming caffeine. So it's extremely important to stop caffeine before starting a trial of a stimulant. Headaches usually only occur when people are not eating and drinking enough. So potential contraindications. We're going to talk a bit more about pregnancy and breastfeeding and stimulants. The only absolute contraindication in terms of the cardiac is a first-degree family member who's died of a sudden cardiac death. But those individuals usually have been, investigated, and as long as a cardiologist is involved and okays the stimulants, then usually it's okay to start on them, starting low, going slow, and continuing to monitor. If someone has high blood pressure, that should be stabilized into the normal range before being on a stimulant. If someone's struggling with severe substance use disorder, SUD is substance use disorder, then again, that needs to be treated alongside of the ADHD. If somebody has psychosis or bipolar disorder, that needs to be managed and stabilized before starting an ADHD medication. And if someone has seizures or tics, again, you want those sort of to be already managed. The tics are again a rule of thirds. A third get better, a third get worse, and a third stay the same with the stimulant medications. So when we look at stimulants during pregnancy, what we know is that more and more women are entering reproductive years who are being treated for ADHD, and they want to know, like, can I stay on these medications and get pregnant?
Oh shit.
Someone has their sound on. We don't have guidelines to really inform our treatment of ADHD during pregnancy and the postpartum period. And of course, we worry that the fetus will be exposed to a medication that could impact the growth and development. But what we've actually found is that stimulants don't seem to be associated with major congenital malformations. But we really, in every individual, have to weigh the risks and benefits of treatment when we decide on any medication during pregnancy. So, sort of the Center for Disease Control and Prevention says you should take your folic acid, maintain healthy diet and weight, be physically active, don't use substances, stay in contact with healthcare providers. And if you're not wanting to get pregnant, you should use contraception. So all pretty obvious. What I know in my work and many of my colleagues is that lots of women stop their medications of any kind as soon as they find out they're pregnant. And some can do just fine during pregnancy and postpartum with breastfeeding without medications. Others will have really significant impairment and quite severe consequences. So if you're somebody who really struggled before ADHD treatment, like problems with driving, getting into accidents, troubles with work, finances, taking care of oneself, relationship difficulties, using substances, and those were better managed on treatment, then it's probably kind of risky to go off the medications during a pregnancy, because what you don't want is to lose a job right when you're going to need benefits. You don't want to get into trouble financially. You need to take care of yourself in terms of your diet and taking folic acid and attending to appointments. Relationships are super important because you're going to need supports in place. And of course, substance use during pregnancy is detrimental or has negative impact on fetuses. So we want to avoid the risk of relapse. So when we look at safety of stimulants during pregnancy, we know in all pregnancies, the baseline rate of congenital malformations is 3%. When we look at all the literature of stimulants that are used during pregnancy, the problem is we can't really tease things apart perfectly because many women have comorbidities. So they're not just on a stimulant, they're also on an antidepressant or a mood stabilizer, an antipsychotic as well. There are women who are also using or abusing substances. So it's hard to kind of say a stimulant is directly causing a negative outcome. In a recent study, the reported congenital anomalies in 4 out of 180 who were exposed to stimulants was only 2.2%. So that's below that 3%. In another study of women who are actually abusing methylphenidate, there were higher rates of prematurity, growth retardation, and withdrawal symptoms in the baby. But a lot of these also had exposure to substances like alcohol, drugs, and smoking. So this was a big study that took almost 2 million women from the US and 2.5 from the Nordic countries. And in this study, they actually found small increased risk of cardiac malformations with the methylphenidates, but not with the amphetamines. And then in this Swedish study with about 1 million infants, only 0.2% had been exposed to ADHD medications, but in those, there was a higher likelihood to be admitted to the NICU, increased risk of seizures and preterm birth, but no increased risk of congenital malformations. So overall, the ADHD medication users in these studies were found to be younger, overweight, and single, more likely to smoke and use other medications and substances. So really the conclusion here was that, yes, we need to pay attention to this, but it's not a reason to stop treatment during pregnancy if the treatment benefits outweigh the risks, and that they couldn't make this sort of direct cause and effect link between the medications and outcomes. So this was a very recent meta-analysis that sort of looked at all the literature and concluded that it is controversial whether there's any increased risk of adverse outcomes to the mom or the baby associated with ADHD medications. There is this increased association with NICU admission, that the methylphenidates were marginally associated with increased risk for cardiac malformation, but there was no increased risk for any other adverse maternal or neonatal outcomes. So then when we look at stimulants, again, we have very limited data. We worry again about what's crossing over from the breast milk into the baby, and that will impact their growth and development and sleep. So in this very small 3 moms taking dextroamphetamine, they didn't find any adverse event. The level found in the plasma was really low. In the literature, they sort of look at the 10% cutoff being in the infant dose, and in this study, only 5.7% was in the infant dose of the maternal dose. So there are alternatives, obviously, to stimulants. Before I sort of looked at this literature, I was sometimes switching women over from stimulants to bupropion or Wellbutrin. Reasons to do this would be if people aren't tolerating the stimulants, or there is sort of some worry about outcomes on stimulants, but also if somebody's already been stable on bupropion before getting pregnant, or because it's a good antidepressant and can help with smoking cessation, that can be good to sort of kill a few birds with one stone, so to speak. And that, there's lots and lots of women who have been on Wellbutrin or bupropion during pregnancy, and the birth defect rates are very similar to the general population. And the dose in the breast milk is actually very low as well. So really you sort of have to ask the question, like, should ADHD medications be stopped before, during, or after pregnancy, or continued throughout? And that's that risk benefit. Should you adjust the dose during or after pregnancy? And should breastfeeding be encouraged or discouraged based on the need for ADHD medications? So then when we look at postpartum, so we know that in that postpartum period, we can really see a significant increase in ADHD symptoms. So this is in part due to sort of the hormones. So we see the prolactin remain elevated. We know that can have some negative impact on cognition and effects on dopamine and norepinephrine. But of course, that's also just a stressful time. When you have a baby, everything, all routine and structure and sleep and exercise and everything gets thrown out the window. And people with ADHD thrive on routine and structure and getting exercise and eating well and sleeping well. So what we've actually sort of seen is that a lot of women in that postpartum period can have sort of their first onset of symptoms of ADHD that are causing impairment. And lots of times they can develop into anxiety and depression. In our clinic here in Calgary that treats women in the perinatal period for mental health concerns, they actually have been finding that many of the women that they're seeing, so up to 40%, actually need to be further evaluated for ADHD. And in fact, the more anxious, so the more severe their anxiety, the more likely they were to have ADHD, and the more depressed they were, the more likely they were to have ADHD. So this is, again, this sort of period of change, period of transition that has, again, hormonal impacts that can really result in sort of a worsening of ADHD symptoms and then develop into those comorbidities. So ADHD and menopause. Well, we know that leading up to menopause, we see a lot of fluctuations in estrogen for up to 5 years before we really see sort of the depletion in estrogen after sort of the last menstrual period occurs. And we've talked already a lot about estrogen, how important it is for our cognition, for our moods, for our circadian rhythms. And so what we see is that a lot of symptoms in menopause, like low energy, pain, sleep problems, memory problems, actually overlap with ADHD symptoms. So this can be another period of transition where hormones are implicated, but also there's life transitions that are happening that can result in, again, sort of symptoms of ADHD that are causing impairment. And, you know, it's interesting to note that changes in our memory are actually happening years and years before they start getting studied. And that it's really probably more important to look at reproductive age and hormones than actual chronological age when we want to understand better the memory circuitry in women. And sadly, dopamine starts to sort of drop off in the 30s and then continues at 10% loss per decade. So this sort of midlife drop in cognition and executive functioning that's quite common a complaint for women in perimenopause, postmenopause, is related to that sort of fluctuation in hormones and that eventual sort of drop off of the estrogen. And that executive functioning that happens in the prefrontal cortex is really impaired by the decrease in the estrogen. So when we see the drop off in cognition in terms of attention and memory, it's likely very correlated or connected to the drop in estrogen. So in terms of treating menopausal decline in that sort of executive functioning, we have to think that medications that increase dopamine are going to improve executive functioning. And there was a big study that actually looked at lisdexamfetamine or Vyvanse in women who didn't previously have an ADHD diagnosis, but were having these sort of subjective complaints of problems with their memory and attention and so on. And it was found that in all areas except for working memory, task performance, that it actually improved their executive functioning. So this just sort of looks at that overview in terms of the improvements that we're seeing with a stimulant in place for women in that menopausal period of time. So, the goal should be when we're working with somebody with ADHD is to look at, how impaired are you by your symptoms in different areas of life. So work and school, but also relationships, social interactions, really working collaboratively with your doctor on defining your goals, making sure medications are taken daily, but also that there are pills and there are skills, or there are pills and there are the pillars. So if you're not eating well, you're not sleeping well, you're not exercising, and you don't have kind of a good, daily routine and structure, there's no pill that's going to magically improve or take away symptoms. So you need those pillars in place to have a really strong foundation on which to put the pills in order to have good results. And so, working with somebody who can help not only get on the right medication, but also look at how do you improve your sleep? How do you improve your sort of daily routine and structure, and trying to get onto a healthy diet and an exercise routine of some kind. So working with like a coach or a therapist, a psychologist, getting into a group of some kind is really, really important to go along with the pill part or the medication part. So just in conclusion, I think, what we really know and what we have to work on is the fact that girls with ADHD tend to be overlooked or misdiagnosed and diagnosed with sort of the comorbidities of the depression, the anxiety, the eating disorders. But that there's a lot of functional impairment that results for these women who aren't diagnosed and treated. And that the hormonal fluctuations starting in, the teen years and continuing through to adulthood really affect ADHD symptoms, but also the response to the medications. And so it's important that you get assessed and managed not only for ADHD, but also any comorbid conditions. And that, tweaking the dose of medications throughout the menstrual cycle, but also at, different points in time in life is often necessary. And that, if you're going through a pregnancy, that stimulant treatment needs to be determined looking at risks and benefits, and it should be a collaborative decision-making process. But that, we're seeing the risk to the fetus is minimal on the long-acting stimulants. And then, lastly, considering the impact of menopause in women with ADHD, and that you need to have not only the medication, but also those sort of psychological and social interventions, to help manage ADHD through the life cycle. Okay.
All right, great. Thank you, Dr. Blank. That was a very informative presentation. So we really appreciate you being here. So there is a few questions here. So if you have some time, I'll just start in order. And if anyone has any questions, please type them into the chat box, and so we can get them answered, okay? So the first question I have is, what about hormone shifts for boys during puberty? Do they adjust like it does monthly for girls?
No, I would say that boys don't go through sort of a monthly hormonal cycle in the same way as girls do. That being said, I mean, obviously the impact of shifting hormones in adolescence for boys and through through the lifespan is something that does have to be considered in terms of the impact on ADHD symptoms and behaviors. So we do see often kind of an increase in ADHD symptoms occurring in the adolescence period when they hit puberty, and there's an increase in testosterone and oftentimes more risk-taking behaviors, more hyperactivity, more impulsivity.
Okay, great. All right, the second question is, have there been studies looking at sleep apnea and ADHD? Having worked with many younger children with ADHD, parents often comment about difficulty with sleep, getting to sleep, and also waking up in the morning.
So yeah, it's not an area of expertise of mine, but definitely having a sleep assessment done is really important in somebody who's had lots and lots of struggles with sleep that aren't improved with ADHD management. If someone has undiagnosed and untreated sleep apnea, then we know there are lots of negative, health and mental health outcomes that can occur as a result of that. So having it assessed and having it managed will often improve ADHD, because if somebody's not sleeping very well, the symptoms that present when we're sleep deprived overlap with ADHD. So if you have ADHD and sleep deprivation, it can really compound kind of the severity of symptoms and the impact on functioning.
Okay, great. Is there off-label use of higher doses of Vyvanse post-menopausal?
There's, I mean, as clinicians, we end up using, medications off label if we found clinically that, they're effective in particular patients. Obviously, we want to sort of start by using, evidence-based practices and using medications that have been studied to treat, certain disorders. That being said, every individual is going to be different in terms of their physiology and their metabolism of medication. So some individuals who are rapid metabolizers will often kind of chew through their stimulant medications more quickly. Individuals who have a history of significant substance use disorders will often need higher dosages of stimulant medications and sometimes need sort of extra top-up dosing in the afternoon to extend the duration. That's something I do with many patients regardless, because if they're needing coverage for 16 hours and a medication only lasts 8 hours, then they'll need often a second lower dose of that same medication in the early afternoon to carry over the effect into bedtime. But in terms of sort of post-menopause, I don't think we have really like data out there that says that that there's a particular need for off-label higher dosing of stimulants. I think it's going to be individual based on how somebody is responding to medications, and for some they will need higher doses than are kind of indicated.
Okay, what are better antidepressant choices for ADHD in women? SNRIs? Question mark.
So I did touch briefly upon this. So because a lot of people with ADHD develop depression, develop anxiety, get put on antidepressant medications, what I mentioned is that the SSRIs, so that would be Paxil, Prozac, Zoloft, Cipralex, Celexa, Luvox, they're good medications with lots of evidence behind them that can really help with mood and anxiety. However, over time on some of those medications, individuals will experience sort of a flattening effect where they start to feel kind of a bit blah, where they're maybe not so depressed or not so anxious anymore, but they're just not really energized or not feeling really motivated to do things. And that can be because over time, serotonin in that SSRI medication form can actually cause decrease of dopamine and norepinephrine. So in my patients who have ADHD and depression and anxiety, where I need to treat those separately, I tend not to use a lot of SSRIs. I tend to use like SNRIs. So they're driving both serotonin and norepinephrine. So that would be medications like Pristiq and Cymbalta. NDRIs, so that would be like Wellbutrin, some newer medications like Trintellix or vortioxetine. So there definitely are some antidepressant medications that tend to work better for individuals with ADHD and depression and anxiety.
Okay, have you noted the development of tics after taking Concerta for a long period of time, aggravated with caffeine?
Well, that's a very specific question. I think, if any side effect develops over time, which it can do, like normally we see side effects happen early on in treatment or as we're increasing the dose, but certainly I've seen it happen where side effects can develop after a patient has been on a medication for an extended period of time. So tics could be one of those side effects. And if that occurs, I think generally the rule would be to try decreasing the dose and see if you get some resolution. If that doesn't improve, then what I would do is switch to another medication. And often what I would do is switch to another class. So Concerta was given as the example. So if a patient's on a methylphenidate like Concerta or Bifenton or Foquest, and they're developing a side effect that's intolerable, I would probably switch to the amphetamine class like the Vyvanse or Adderall, and vice versa.
Okay, if someone is postmenopausal and is on meds post heart valve replacement due to structural defect, did you say under the cardiologist, they can use a stimulant?
Well, what I would do, again, it's a really specific question, is in my practice, if I have a patient who has, a specific cardiac, illness or disease, and they're seeing a cardiologist or a neurological or an endocrine, what I do is I consult with their specialist and ask them whether or not they feel starting on or being treated on a stimulant medication is safe for that particular individual patient. So it does have to be unique to that individual, and it is best for the specialist, so the psychiatrist or the physician treating, to work with the other specialist to make sure that the medication is safe. And anytime there is, a concerning illness, medical illness, it's better to kind of start the medications at a lower dose and follow kind of more closely to make sure that there's not any sort of negative effect or worsening of the medical condition.
Okay, thank you. Are tics more likely to develop with some stimulants than others? And if tics develop, does dose reduction to the stimulant ease tic symptoms?
Yeah, so I think I already answered this, but I don't think there are specific stimulants linked to tic development. Generally speaking, if a specific medication increases tics, so like I said, it's the rule of thirds. A third get better, a third get worse, a third stay the same. So if it's the case where they're worse, then yes, you can try reducing the dose, but if that doesn't help or it's then not treating the ADHD, then the practice would be to switch to another medication and often to the other class. So from amphetamine to methylphenidate or methylphenidate to amphetamine.
Okay, so the next question is there an argument for perimenopausal and menopausal women with ADHD to not only increase dose of ADHD meds due to reduction of estrogen, but to take estrogen in an effort to improve ADHD?
Yeah, I think there is an argument. I mean, again, it's very individual. So, not all women are safe to go on hormone replacement therapy based on their family history and their own personal history. So again, as long as you're working with, your family doctor or your gynecologist and that it's deemed safe to be trialed on hormone replacement or estrogen along with a stimulant, then I think it's definitely reasonable to give it a try. And yes, it's possible that, just like kind of going through the menstrual cycle where you have the drop off of estrogen kind of post ovulation, that perimenopause, postmenopause, some women who might have been stable on a certain dose of a stimulant might find at that period of time that they need a higher dose. I mean, there's also anytime a patient of mine has been stable on a medication and comes saying, I don't think my meds are working anymore, I want to know what's going on in your life. So the meds don't stop working, life stops working. So like I was talking about, there's the skills in the pills or there's the pills in the pillars. And so if you're not staying on top of the basic foundational pieces of sleep, diet, exercise, routine, and structure, which can really shift, as people are maybe postmenopausal and maybe they're empty nesters, the kids are, moving out of the house, maybe they're going into retirement. Their life structure is probably starting to shift. And so it's really important to look at and tweak those pieces instead of just assuming an increase in medication is going to magically sort of treat symptoms.
Okay. So what is the role of HRT in perimenopause, postmenopause?
I think what I just talked about, I think, you need to work with your clinician, and if they feel that that it's safe to trial estrogen, I think it's reasonable to work with them. But again, it's going to be, an individual sort of risk benefit in that case. I don't think we have a lot of evidence right now, kind of looking at HRT in women with ADHD in perimenopause, postmenopause. It's probably an area that we really need to look at more closely. But it's also all kinds of hormone entered into the system are important to evaluate. So even oral contraceptive pills or IUDs with hormones in them are important to look at kind of through the lifespan, because if you're on something that is higher in progesterone than estrogen, that can actually have a negative impact on cognition and can impact sort of mood and anxiety.
Okay, thank you. So would birth control pills help with menstrual cycle symptoms? I think that's what the question is.
Well, that's what I was just talking about. So it depends. For some women, yes, because if it can really stabilize the shifts in hormones throughout the cycle, then that can be very, very helpful. However, it's again important that it's not this a higher progesterone oral contraceptive pill, because we know that can have some negative impact on cognition and ADHD symptoms.
Okay. Does puberty lead to medication not being as effective? As in, does the onset of puberty lead to medication dosing needing to be changed?
Possibly. Yeah, and that's again because you're starting to see sort of quite a significant shift in hormones, and for boys and girls in puberty. And so if somebody's being diagnosed younger and stabilized on a certain medication, there's a lot that's happening in childhood and adolescence, not just hormones, but growth and development. And so physiology is changing, weight is changing, activity levels, demands on cognition. So I think just sort of reassessing and evaluating the effectiveness of a medication is important, kind of as individuals go through life transitions. So, going from childhood to adolescence, adolescence into adulthood, etc.
Okay. Can ADHD develop as an adult, or does it always begin in childhood, but is just not diagnosed?
So, I mean, it's a good question, and there is actually some, I would say, sort of controversy within sort of like experts in the field. So generally, it's considered a neurodevelopmental disorder that people are born with, that, like I said, is highly inheritable, runs in families. That being said, there are many, many people who don't get diagnosed until adulthood. And that in part might be because of some of the things we talked about, that, they're getting diagnosed and treated with other things like mood and anxiety or disruptive disorders or learning disorders. But also it can be because people are managing pretty well. So to get a diagnosis, you have to not just have symptoms, but be functionally impaired. And lots of people growing up are bright and they're high functioning, and they've got really good support systems in place in the form of their parents and teachers and coaches and friend groups, etc. And if they've got good outlets in terms of physical activity and they're getting good sleep and they're eating well, they might not be very symptomatic at all. But we see these sort of transition periods of time, like when kids go away to university for the first time and they're on their own and they're having to take responsibility for all these things that were really, managed prior to leaving home, like that sort of scaffolding that parents provide and that external executive functioning, getting them up, getting them fed, making sure they're doing their homework and handing in assignments and getting to bed and taking devices. Like all that's gone if a kid goes away and they're on their own for the first time. So I treat a lot of university students who were never diagnosed. It was never even on anyone's radar until they hit university, and especially sort of more demanding. Like I treat a lot of kids in professional programs like medicine and law and so on, where the demands kind of outweigh their coping strategies, and COVID has made that even more difficult. So all these strategies that they've developed over time to manage have gone out the window when you can't be in a live classroom and be engaged and asking questions, but everything's being done online and virtually, or you can't study with friends or get out of your house and go to the library or exercise in the way you used to. So for most people, ADHD is something that they're born with, but it may present at certain periods of time, like that university time, or when people have their first real job, or after having a baby, or, you know, in that sort of perimenopausal time. There are people who can develop sort of secondary ADHD after sort of a head trauma, or a bad concussion, or even an infectious illness affecting the brain. So yes, we see a lot of people getting diagnosed in adulthood, most of whom have had ADHD all their life, but it was never, you know, either impacting them or it wasn't appropriately assessed and diagnosed.
Okay, so we have quite a few questions here, so I'm not sure how much longer you can stay, but I'll keep going until you tell me to stop. So have hormone reactive chronic illnesses as a comorbidity been studied?
I'm not sure what that question means.
So they say they're recently diagnosed with endometriosis.
Oh, endometriosis. You know, I don't know the answer to that specifically. I mean, I think it's a good question. I think if there is any sort of underlying kind of endocrine disorder that it has an impact on hormones, particularly like we've talked about the estrogen and progesterone, that it probably is going to have an impact on ADHD. So, you know, when we see, for instance, like polycystic ovarian syndrome, we do see an impact on levels of estrogen and progesterone. And so it's, you know, it's a really good question, but I don't know the literature on it. But I think anything that's going to have sort of higher progesterone, lower estrogen is going to have an impact on cognition and ADHD.
Okay. Is this information, as in the information you just presented, being put into education for psychiatrists about ADHD and women?
Well, I do a lot of educating psychiatrists and family doctors and other mental health clinicians. And, you know, at the national level, so on the CADDAC board, I also co-chair the education committee, and we're developing a lot of resources like an online big platform for assessing, diagnosing, and treating ADHD. We're providing kind of, you know, fireside chats for clinicians. We also have an advocacy committee that's, you know, advocating for increased awareness at the training levels. So, you know, teaching about ADHD in medical schools and residency programs. You know, I've been working at this for over 10 years, and it really is still not very well taught in medical training programs, unfortunately, but it's getting better. And of course, my hope and my goal is that, you know, it will get to the same, you know, place as depression and anxiety in terms of awareness and understanding and treatment strategies.
Okay, great. You might have answered this question, but is there any data on effects of HRT on episodic memory in ADHD women? If so, is there ever a negative effect?
I don't know specifically episodic memory. I mean, I think no, I don't really know the answer to that question. I mean, I think generally speaking, when, you know, when HRT is prescribed, it's sort of more a continuous treatment, or obviously, you know, the way like oral contraceptives are used, they're usually used kind of in sort of a monthly cyclical manner. So I don't know. I don't know if it's being used sort of episodically, specifically related to that question.
Okay. Are there any studies of this happening to men during andropause?
I don't know about studies, but I mean, I think what we know is that there's a lot more sort of interest and awareness of the cognitive impact of aging and ADHD in an older population. And so I think MCI, or mild cognitive impairment, is something that a lot of individuals get diagnosed with sort of in that later adulthood, older adulthood period, and often it sort of coincides with retirement. So there's a lot more sort of interest in this idea that how many of these individuals, men and women, were able to function well and manage their ADHD well while they had careers and they had clear routines and schedules and had to get up at the same time, and had a support system in place in terms of like secretaries or assistants or people they worked with, and sleep would have been routinized, etc. And then after retirement, a lot of that again is sort of lost and shifts, and these individuals who have been very like highly functioning can start to resent like they're having some cognitive impairment, and there's a lot more sort of interest in how many of these individuals have previously undiagnosed ADHD that they were able to manage, and many thrive in a working environment, but not so much after retirement.
Okay, somebody's asking how they can get a referral to your clinic or an ADHD specialist.
Yeah, so I work in Calgary, and our clinic just is referred to through either our emergency department or the central triage in the city. I think depending on where people are and they're looking for ADHD assessment and treatment, I think it's worthwhile to contact places like CADDAC and CADDAC to see if there are clinicians with expertise in ADHD. I think even if you can't see a psychiatrist or a physician who has that expertise, going to a psychologist or a therapist who has that expertise and getting a comprehensive ADHD assessment from them often is very helpful to then take to your physician to then get started on some good treatment.
Okay, great. I can tell you that CADDAC does compile a list of physicians across the country that assess and diagnose. So we can send that out if you just email info@caddac.ca. However, I will warn you there's a long wait list, especially in BC and Ontario. Okay, so the next question is, I've never been on medication for my ADHD and I prefer not to be reliant on medications overall. Are there supplements, vitamins, or minerals that can help with symptoms?
So we just don't have good evidence for the sort of non-pharmaceutical treatments for ADHD. I mean, things that have a bit of evidence would be like the omega-3s, but that effect size piece that I talked about in terms of the stimulant medication, we actually don't have any other medication in medicine, not just psychiatry, that has an effect size as large as the stimulants, that 0.95. And there have been studies done over decades, just mostly in children and now more in adults, looking at comparisons between medications and all these sort of non-medication interventions. So the MTA study was a really big one. And they really found hands down that the medications were really kind of the gold standard. That being said, of course, medications aren't for everyone and not everybody tolerates them well. So instead of, I think, kind of thinking about or looking at supplements, to me, it's those those behavioral elements and really building on and stabilizing those pillars. So the sleep, the diet, the exercise, developing good routines and structure, and working with someone that can help you sort of manage the symptoms, and it's about doing that lifelong. And that's where it's hard. It's really hard for individuals with ADHD to be consistent. And something is interesting initially, but then it loses its sort of spark, and people often sort of throw the baby out with the bathwater, and systems that were working are no longer in place. But really looking at it as sort of a lifelong process, and developing kind of those consistent behaviors, and really developing those good solid strategies is what's going to result in more stability and better symptom management.
Okay.
Maybe two more questions.
Sorry?
Maybe 2 or 3 more questions.
Okay, 2 more questions. All right. So is there research with respect to the use of IUDs and exacerbation of ADHD symptoms? And this is a twofold question. If so, would it be considered contraindicated in someone with ADHD, and would oral contraceptives be a more suitable option?
So it's really not about IUD versus OCP or oral contraceptives. It's about what are the hormones. So like a copper IUD has no hormone in it. Whereas there are other IUDs that do have hormones. So what's important to know is what are the levels of the hormones, and you want to avoid contraception that has high progesterone. So lower levels of progesterone, and then having some estrogen in place is going to result in sort of a better response and less impact on ADHD than those that have the higher progesterone.
Okay, great. So this will be the last question. Sorry, there's a few more, but so I read that those with ADHD may be more susceptible to PTSD type symptoms after traumatic events. Would women be more at risk of this, and what treatment would be recommended?
So I'm not sure that women are more susceptible than men. I think, trauma is trauma. And if an individual, experiences a trauma and then develops PTSD symptoms, then treatment is really important. There are a number of different treatments for PTSD. Sometimes people need medication to manage, the mood and anxiety components that come along with PTSD, but therapy is also critical. So, prolonged exposure is one form of therapy that has a lot of good evidence. Accelerated resolution therapy, or ART, is a newer form of therapy that is, really gaining in popularity. And I've had a lot of patients have good responses to ART, but it's about finding a therapist who has that training. So I think anybody who has, survived trauma and is experiencing the sequelae or the symptoms as a result does need therapy, whether they have ADHD or not, or whether they're a man or a woman.
Okay, great. So that concludes the questions for tonight. And so I just want to thank everyone for participating, and thank you again, Dr. Binder, for doing this presentation. It was extremely informative. As you can tell by the questions, people were very engaged, and so we really appreciate that. So just to let everyone know, this presentation will be sent out to everybody who registered. So in probably approximately 2 to 3 days, we'll send that out to you. And if you didn't get it, please just send an email to us, and we'll get it to you as soon as possible. All right, so with that said,
thank you very much for organizing, and thanks everybody for your interest and attendance.
Great, thank you. Have a good night.
Thanks.
I'm just waiting for everyone to, all right. So I think everybody's off the call now, and it's just the two of us. So I think things went really, really well. So how did you think it went?
Yeah, it's in like the questions are interesting, right? Because it's very specific to
their situation. I know, and I wasn't sure with all those HRT questions. I was like, did she answer that? Are they answering the same question? I didn't know, but there was a lot of them. I actually skipped through a bunch of those. So like that's hormone replacement therapy. So it's a common thing.
Well, you know, it used to be super common kind of in postmenopause to put women on like estrogen, but then there was, you know, a period of time where the risk of developing breast cancer and blood clots and stuff became, and then people stopped, and now it's kind of, I think, more acceptable, but it's very individual. So you can't just say, oh yeah, everyone should go on HRT. Like it's something you need to go talk to your doctor about in your family history and your own history, whether or not it's like safe.
I see. Yeah, there's probably another 8 or 9 questions. Yeah, so I think it kind of could have went on forever.
Right.
But they were engaged. So, and we had, I think, just under 100 people on the call.
Yeah.
That's a lot, and they stayed on it, right? So a lot of times people fall off the call, they come on and then they kind of drift as the presentation goes on. So that's great. So again, I really appreciate you doing this. So I just need you to send me an invoice.
Oh, okay.
Yeah, so that we have it on record and then I can get you paid.
So how does that work? Like I send it to you and then it goes to whoever it was with.
Oh no, we pay for it. Yeah. So CADDAC will send you the money. We usually just email money.
Didn't you get support from
yeah, we did.
You?
Yeah.
Oh, okay, but I just give it to you.
Yeah, so for like typically how it works for our webinars, workshops, like any event that we do put in funding usually at the beginning of the year to CADDAC, Janssen, and Purdue or Albion. Yeah, so we get funding to do this type of stuff. We used to actually charge for webinars, but then last year when COVID hit, we got quite a bit of funding from the pharmaceutical companies to just go ahead and run these things. So we just started doing it free. We started giving it, and I think as more people get on there and more people just need it. I think it's a deterrent to charge people, even if it was only $10. I thought it was a deterrent. So I think it's just better. More people have access to this. I mean, some people were chatting there saying that, you know, they're in remote areas, they don't have access to services. And so again, right, this is just another barrier by making them pay. So I think this is something that we can do. It's easy and
awesome.
We get funded. So
okay, so you don't have like a form, you just want me to send you something.
Yeah, as long as it just has like, really just like your name and just saying like it's an honorarium for the webinar. That's really good. We just need it for accounting purposes because they always get on my case when I'm giving out honorariums, and I've tried to say, well, I don't really want to have an invoice, but they insist on it. So yeah, if you can do it and if it's not too much trouble.
No problem.
Okay.
Yeah.
Okay.
I'm just reading the chats now.
Oh, okay, yeah, they're still there. Yeah, and I can send you the chats too if you like. So 15 new messages. Oh. Yeah, thank you. Yeah, you know, it's interesting though, because when doctors come on, like medical doctors, there's so many questions about medication, and they get very, very specific too. Yeah, but it's good.
Yeah, I recognize, like, just as I was at the beginning when I was seeing people's names, I did recognize a couple docs.
Oh, a couple doctors. Oh, that's great. Yeah, every once in a while we do have doctors, like even at our conferences when they're face to face, we do get doctors that come, and I do let them know about CADDAC in case they don't know about CADDAC, because it might be a bit more relatable to them. Yeah, but yeah, so yeah, most of our audience is parents or individuals. And obviously on this one, I don't know if you, like, I was looking at the participants, they were basically all females. Yeah, there wasn't too many men on the call, so.
Yeah, except right at the beginning, that guy. Yeah.
Yeah. And the thing is too, I'm not even very good at, like, normally I don't moderate the meetings, but it's just that it was so late here that I couldn't ask somebody, one of the staff to do it. Yeah, so I do it. I didn't know how to do stuff. Like, I was trying to mute and then I muted you, and then I was worried that I was going to do it again, but I kept hearing background noise.
Yeah.
So I was looking to see who was making the noise and trying to mute them. Yeah, so.
Yeah, it's 11:30 your time. You need to go to
It
bed.
is, I know, I'm exhausted. I'm someone that goes to bed at like 10 o'clock too. So
oh, okay, yeah.
I have no issues with sleep, so.
Okay, all right, awesome. Okay, well, thanks for organizing.
Yes, thank you so much. And I am going to send you an email just to ask you about that paper. So I'm really interested in it.
Oh yeah, and you'll send me the recording, hey?
Absolutely, yeah. So we might use
this is
that
like
paper.
A link, or?
Yeah, it'll just be a link. It'll just be a link. So we'll clean it up. So at the beginning, we'll erase me and you talking at the beginning, and then this is being recorded also, so it'll be erased, and it'll just be your presentation with the question. So we'll go probably right until the end of the question. We'll cut it off. Yeah. So.
Okay.
Yeah.
Awesome.
Okay. Perfect. Okay. Have a good night.
Thank you. Yeah, you too. Okay, bye.